In the S node and AV node, there are no fast channels, and the upswing, essentially phase 2, of the action potential is slow because the depolarization is produced by calcium entering through slowly activating L-type calcium channels. The pacemaker potential depends on several currents, including an outward potassium current, which gradually decreases, and 2 inward sodium currents, which are relatively stable. As the potassium current decreases, the sodium currents cause increasing depolarization until threshold is reached and an action potential is initiated. The slope of the pacemaker potentials in the S node is greater than in the AV node, and so the S node normally determines the heart rate sinus rhythm. The pacemaker and conducting cells receive autonomic innervation. Here, 2 neurotransmitters are responsible for conduction that are acetylcholine and norepinephrine. Vagal fibers release acetylcholine into M2 muscarinic receptors that open a potassium channel via G-protein coupling. The increase in potassium conductance causes a hyperpolarizing current and decreases the slope of the pacemaker potential. Thus, the threshold for firing is reached later and the heartbeat slows. Acetylcholine also inhibits atrioventricular conduction, whereas sympathetic fibers release norepinephrine on beta-1 receptors in the pacemaker tissues and myocardium. Norepinephrine increases the inward sodium current, and so threshold is reached earlier and the heart rate increases. Norepinephrine also increases the force of contraction by increasing the influx of calcium during the plateau phase, which is commonly known as positive inotropic effect.